Welcome to the Research Works podcast, brought to you in association with the Healthy Strides Foundation. Your hosts are Dr. Dana Poole
and Dr. Ashley Thornton, and we're here to interview world-leading researchers, clinicians and people with lived experience
to support your practice in being more evidence-based.
Hello, everyone. Thanks for tuning in again as we delve even deeper into our new season 5 of the podcast.
Season 5, here we go, my goodness. And we've really been getting so much great feedback of the episodes so far. I'm glad you missed us and you're right back into the episodes again, which is fabulous. And today we are in for another very special treat because we have 2 guests joining us today, representing different parts of the globe, really. So thank you so much for joining us. Anita grows from the Master University in Canada and Dr. Nikki Milne from Bond University in Australia. Hello, everyone. Hi.
Hi.
Hello. Thank you for having us.
Oh, thank you.
Hi.
Thank you. Thank you for staying up late to speak with us. Look, today we're going to talk about something it's quite different but really important and quite topical. We'll be talking about a recently published paper in the Journal of Manual and Manipulative Therapy in 2024, and it is titled Spinal Manipulation and Mobilisation in Paediatrics, an International Evidence-Based Position Statement for Physiotherapists.
Wow.
Excited. So good.
I'm excited to unpack that. I'm excited that we get to do it with 2 really special guests from across the globe. But before we do that, let's tell everyone about Anita and Nikki. And we have 2 bios to get through for 2 guests. So we'll start with you, Associate Professor Nikki Milne, who is an experienced paediatric physiotherapist, researcher and educator with over 2 decades of expertise in child health, fitness and health professional education. Nikki is the paediatric lead for research and coursework in the physiotherapy department at Bond University, which is located on the Gold Coast in Australia. And she's also the Assistant Dean of Research for the Faculty of Health Sciences at Medicine. Her research focuses on paediatric motor development, physiotherapy education and student-led school health programs with collaborations across New South Wales Health and Education departments. She's on the Executive Committee and Board for the International Organisation of Physiotherapists in Paediatrics and has led several major projects, including the Paediatric Spinal Manipulation and Mobilisation in Infants, Children and Adolescents Position Statement and an international Delphi study on entry-level paediatric physiotherapy curriculum. You sound busy, Nikki.
You do.
And a little.
And Anita. Anita Gross is a clinician, researcher and educator specialising in orthopaedic manipulative physical therapy, with a distinguished career spanning over 3 decades. A Fellow of the Canadian Academy of Manipulative Physiotherapy since 1990, she has been recognised with the Lifetime Membership Award and a Medal of Distinction from the Canadian Physiotherapy Association for her contributions to the profession. Anita is an Associate Clinical Professor at McMaster University and the Director of the IOPTP Field Study in Rehabilitation Sciences, in addition to lecturing at Western University and the Advanced Integrated Musculoskeletal Physiotherapy Program in the Canadian Physiotherapy Association. Her clinical expertise focuses on neck and spine care, and she is committed to advancing evidence-based physiotherapy practice and education.
You are incredible. That was a great bio to read as well. Anita, you seem equally as busy too. Thank you for joining us in your very busy schedule.
Yeah, and I think those bios just highlight, how knowledgeable and experienced you both are in this field and on the topic we're about to cover today.
Yeah.
So that's our formal getting to know you. But we also like to do an informal getting to know you. And we do that with our icebreaker question. And our question for today is, what is your go-to guilty pleasure TV show or movie? And I say guilty pleasure, but when I think of that, I think of, something that's really comforting, that feels like an old friend. You can just sit on the couch with a blanket wrapped around you and switch your brain off.
Yep, that's a good one. Should we go guess first? Nikki, are you ready to go on this one?
Oh,
yeah. Okay, cool.
I think the comfort side for me is when it's all family members in for a movie or a TV show, but probably our go-to series over the last 12 months has been Yellowstone, which my husband and I kicked off a few years ago, and then our children decided to start watching it. So we did a redo with the kids on the lounge because I think my son secretly wants to be a cowboy.
And who wouldn't after watching Yellowstone?
I haven't watched that one yet, but I'm leading into it. I'm on 1923 at the moment. So
it's good too. But
Yellowstone.
It's like a
definitely
whole
recommend
world,
Yellowstone.
isn't it?
Yeah.
It's a whole.
Yes.
It's quite involved. There's spin-offs but
Yes.
I'm not fully across the timeline of when they all happen, but there's a certain order that you probably should watch them. Is there or?
Well, Yellowstone hit Australia first, so I don't know if that is true all over the world. But so that was where we started, and then there's prequels, sequels, spin-offs.
Yeah. That's
good for switching off from work. That's for sure.
Yeah, because you
like
get completely immersed in that world.
It's a whole new world.
Yeah. Anita, what about you?
Well, we do the family thing too, but we watch Jeopardy and
Jeopardy.
debate and discuss and anyway, don't always get all the answers, but it's pretty good.
I love that.
I don't get all the answers, let's say that for sure. But my husband works on it. So the whole family's on that one.
That's so good.
I love that.
Very interactive. Yeah. You guys must be great at quiz nights.
Yes.
Then. I'm terrible at that. I don't have great general knowledge.
Me neither.
Oh, that sounds fun.
What about you, Dana?
Me, my head goes in many directions because I don't actually read much. I feel like I read so many academic papers that I don't feel like reading anymore when I get home. So I do love watching television. And my guilty pleasure in a way is like I love a good Western. And you saying Yellowstone, I was like, I haven't seen that one yet. And I'm trying to get to that. Maybe because I don't have Paramount. I've got so many subscriptions, but you got to add another one to it.
Know.
Yes, and they keep changing.
They keep changing. So you're like trying to budget your way through it. But I love a Western.
I didn't know that about you.
Yeah, and I've only really started to verbalise that recently because I was actually born and grew up in my first 12 years of life in Canada, in Calgary, which is the home of rodeo. And so everyone was kind of like having a good cowboy hat and the boots was a really normal thing. And I think that's why I really enjoy it. So when a movie comes on and it's a Western, I'm like, yes.
It's comfort.
It is. It's comfort. I get right into it. Yeah. What about you?
There's so many. More recently, I feel like my comfort show or my go-to show has been Ted Lasso.
Ted Lasso. I've seen that come up. What's that about?
So it's about an American guy who is recruited to go and manage a football team in the UK. So Jason Sudeikis plays Ted Lasso, who's very funny. I think he might have written the show as well or been one of the writers on the show. But it's so far removed from reality. Yeah. But it's a really heartwarming, feel-good show.
That is nice.
It's really funny. Yeah. So
gone for the humour.
Yeah, I like that one. Yeah. I also really guilty pleasure Bridgerton.
I do love Bridgerton too.
Oh, yes.
Yeah.
New unreleased. I think they've just dropped a new series.
No.
So.
Really? Hot off the press.
Yeah, I think so.
You heard it here first.
Gosh.
Not through the Netflix marketing agencies for the Research Works podcast.
Well, I guess
if I can trust my daughter anyway. That's what she tells me.
Yeah.
Okay.
I love it. Yeah. And then I love all the comedies. I love Seinfeld and The Office, but, I do love a good Western as well.
There you go. I feel like we could do a whole episode. But we won't. We won't.
Let's go back in our wheelhouse and let's talk about this very exciting paper. So let me give you a rundown of what we'll be talking about today. So this spinal manipulation international statement is an evidence-based position paper developed by an international task force of physiotherapy clinician-scientists to guide the use of spinal manipulation and mobilisation in paediatric populations. The study synthesises existing literature and expert consensus to provide recommendations on the safety and efficacy of these interventions for children and adolescents. The key conclusions indicate that spinal manipulation and mobilisation should not be performed in infants, nor should cervical and lumbar spine manipulation be applied to children. Furthermore, the interventions are not recommended for treating musculoskeletal conditions, such as asthma, ADHD, autism, and cerebral palsy. However, spinal mobilisation may be appropriate for certain musculoskeletal conditions in children, and thoracic manipulation may be cautiously considered for adolescents with spinal mobility impairments. There's a lot to talk about there.
Mm-hmm.
Yeah.
It certainly is. So, Anita and Nikki, could you give us a brief overview, I suppose, of the background to this paper and a bit of context? What motivated the need for an international position statement on spinal manipulation in paediatrics?
Yeah. I'm happy to address that one.
Yeah.
I guess in Australia here we had a number of years ago a bit of media coverage about some chiropractic manipulation of infants. And I'm not sure if you saw it, but it blew up in the media quite strongly. There was a lot of frustrated clinicians from not just physiotherapy, but from the medical practitioner world, from, a number of different professions. And so that really ignited a very big conversation about this topic. And as a result of that, we had some members of the physiotherapy profession all over the world, actually, because that media coverage really went international, asking what was the IFOMPT, which is the organisation that Anita is connected to, it's the International Federation of, they've just changed names, Anita, haven't they? So
Manual and musculoskeletal physiotherapy.
So they were being contacted by members all over the world asking, what's your position on this? Like, should we be doing it? Should we not be doing it? And so it ignited a great conversation for our profession. And it also sort of ignited debate for and against it for different groups in the physio profession. And then there was a number of people saying, we're not sure. We don't know how to manage this situation. And we don't know how much this is actually happening in the physio world. And as a result of that, they established the Paediatric Spinal Manipulation Taskforce, which is where Anita and I were able to join forces. And Anita has been like an amazing chair of that task force for the last 5 years now, and it's really been the driving force behind a series of studies that we undertook to try and come up with a position statement, which essentially we set out to first synthesize all of the literature we could possibly find on this topic. What were these techniques being used for in terms of manipulation and mobilisation of the spine to treat what impairments, what conditions, etc. And then to gather information from our profession, the clinicians, what were they saying about it? How much were they using it? How much did they think it was appropriate to do these techniques and with what populations? And then also we went through this refinement stage of heavy debate actually between the members of the task force. It was many, many hours of debating the findings from those two big stages of our research, and then coming up with an evidence to decision, or using an evidence to decision framework, which had been used in previous research to summarize all of those findings and undertake a gap map analysis, which Anita really drove that stage of the research as well. And so we did all of that to be able to reach our ultimate aim, which was to develop a position statement to guide the profession on the use of spinal manipulation and mobilisation with paediatric populations, so infants, children and adolescents.
Wow.
So
and
it's been a journey.
I bet.
It was. But the group really included a lot of both clinicians and scientific kind of experts from both the IOPT and IFOMPT. And once we got started, we noted that we needed some extra help once we were on the go. And this is where the task force, we decided we needed some specific methodology or had specific methodology needs. And this is where Jennifer Dice and Jean-Michel Bismy and Friedrich Farment had expertise in Delphi surveys and design on manipulation. In the U.S. population, we pulled them in. So our group slowly grew just a little bit in order to get the full methodology expertise that we needed.
It's incredible. And I think, perhaps you could just, you've mentioned a few names there, but just to give our listeners an appreciation for how collaborative this task force is, can you kind of just give us an overview of, how many members do you have in this task force? You mentioned that there's quite a breadth of expertise in there. So, yeah, who makes up the task force?
I'll answer that. We have, in addition to that U.S.-based group, we had Ken Olson representing the IFOMPT executive. In order to report back to that executive, we had a South African person, Annelies Bastian. She also has expertise in running systematic reviews in the area of neck and other regions of the body as well, and adults primarily. And there was Jan Poole, who had expertise in systematic reviews in clinometric world or psychometric properties of outcome measures.
So comprehensive, isn't it?
And Derek Cluley was also one of our members that come on a little bit later from the US as well to help more with the sort of second half of the activities that we were working on to come up with the position statement.
And his expertise is guideline development from the neck pain world again, the neck pain guidelines that emanated from the U.S.
And it really, highlights, obviously you have people with a wealth of clinical expertise, but in, trying to develop and publish the evidence in the field, it's, you've acknowledged the important role that the scientific experts play in that as well. People with comprehensive systematic review expertise, and it's
Delphi,
really impressive.
Yeah, it's the methodology, isn't it? For it to be robust and for it to make its full impact. It has to have that kind of team.
The other thing about the team that was actually quite hard getting the balance right at the beginning, we needed the different scientific methodology expert, but we also needed the mix of pediatric and orthopedic manipulative therapists because, as you might appreciate, a lot of pediatric physios say, "Oh, we don't do that." And then a lot of the more adult-oriented orthopedic manipulative therapists, they say, well, we don't treat the little kids. And so there was this big void in the middle where we're like, okay, who really is the expert group in the middle of this area? So and that was particularly challenging for us through the Delphi study to ensure that we got the right mix of people in there with the right expertise.
And can I go back to, with all that in mind and sort of where it started, and there was that, I do remember that social media video going viral. I think it was just a 2-week-old baby.
Yes.
And then you mentioned that there was, quite robust debates amongst the members as well. Can you just walk us through why that kind of intervention was provided in the first place? And perhaps maybe we can even touch on the difference between manipulation and mobilisation, because we are talking about both of them separately as well. Do you mind just walking us through that? Because, from the outside, I'm a paediatric physio, but it's mostly neuro and developmental. The idea of manipulating a 2-week-old infant just seems so far removed from what I would ever do.
Well, I'll do my best because a large part of the debate and conversation that we've had has been exactly as you've just mentioned, trying to understand the rationale, the clinical rationale or theoretical underpinnings as to why people would choose to do this. And to be completely frank, we still haven't come to terms with some of that because it's not clear in the documentation of the literature in those areas. And what some people propose, we can't really wrap our heads around. Can't really understand where they're coming from because it doesn't align to the evidence base and the anatomy and physiology that we've learned in our professional backgrounds. So I think that a lot of babies, so in particular the baby that you're probably referring to in the big media, or there's been a few videos like that, those babies might present for chiropractic care for colic, being really unsettled babies, or they might have difficulties latching on for feeding, so difficulty breastfeeding. There's a number of different reasons why babies often present, or for some babies, they'll be born and they might get a referral very early on from some of the health professionals who see them in the first hours of birth, saying, oh, that was a really difficult birth. We think that you should go and have a chiropractic adjustment, or get your baby to have a chiropractic adjustment, or things like that, the parents go, oh, okay. And of course they want to do what's best for their child. So somebody's recommended that, and off they go to see somebody to have a spinal adjustment done. And the way that spinal adjustment is done really varies from what I've seen both in the literature and also in the more media about how they might do that. I mean, I think the video you might be referring to, you saw the baby hanging upside down. So it was just quite frightening for us to see.
Yeah.
Yeah, the relative definition of manipulation is that high velocity, low amplitude thrust. And certainly chiropractors, physiotherapists, doctors, osteopaths might do that technique. The mobilization is more a continuum of skills using passive movements that are applied with lower speeds and amplitudes to the joints, muscles, nerves, with the intent to restore usually some impairment, some mobility restriction, function, reduce pain, something like that.
Right.
There are certainly groups in the physiotherapy world that will do manipulation and mobilization, and we've certainly crossed paths with debate and discussion with those groups in Germany and in the Netherlands and Denmark, and they perform perhaps more mobilizations, but we were very interested in mobilizations equally as so as manipulations. This circumstance that happened in Australia was related to a manipulation, I believe, done by a chiropractic profession. But the physiotherapy profession has a diversity of clinicians, some very specialized in specific types of mobilizations to be performed on infants, and then the manipulations as well.
Interesting. Just before we get into the methodology and the Delphi, because I'm very interested in that, just back to the I guess, colic and difficulties latching as reasons why there was a referral for these manipulations. What was some of the theoretical underpinnings of that for the people who applied it? Did that come out through some of the discussions? Because that's curious to me.
For colic?
Yeah. What was the theoretical underpinnings for them to provide it, even though, Yeah, you go.
There is a very wide scope of rationale and belief about how it assists, how it helps. Some of them talk about neural pathway clearing. Some of them refer to like literal manual alignment of the skeletal system. Some of them talk about ensuring that there's better neural flow if they can manually adjust parts of the spine.
Wow, okay.
Yeah, so there is a great, as we've discovered, multitude of different theoretical underpinnings as to how people progress or why they choose to do it. And for the belief is that if you have good neural flow, then your gastrointestinal systems are impacted at different parts of your neural system, and therefore that might impact, better outcomes for colic. But I wouldn't say it's overly clear, and it's certainly in the research papers that we read, I wouldn't say it's clear.
Yeah. And it's, for parents, you see often there's this real kind of snowball effect almost in parenting forums and people who are desperate to seek answers and relief for symptoms that their baby might have around that relate to colic or reflux and things like that. And often the first thing that people will suggest is go see a chiropractor or go and have a manipulation done. And, anecdotally, they're describing all of the benefits of that. And so you can understand why parents are seeking that out.
Okay.
I had that situation as a parent myself. I had a very colicky baby and gastrointestinal reflux to the extreme. And I was sleep deprived. I was desperate for her to hold her food down so she grew. And I did get contacted by a friend of mine actually who was a chiropractor and said, I'll have this fixed in 2 sessions. And I was like, how? And that person, even as a friend, didn't explain how to me. And of course, I was a bit more protective, thinking about the potential risk of harms that could occur from that. And so didn't go down that road at the time. And as a clinician, I've definitely had lots of families who look for that and they want both. They actually bring them both to physio and to chiropractic or osteopathy, and they do whatever they possibly can to have better outcomes for their kids.
And it's the language around it, right? So better neural flow. I mean, that sounds great. I don't even know what neural flow is, but it sounds,
I like the sound of it.
Sounds nice, but, for someone who's not aware, you wouldn't know that actually isn't a term that we would use in how we would describe things. Thank you for going through that with us, because that was a very curious point for me. Let's quickly duck into methodology now. So as we sort of mentioned earlier, your team conducted, it was a multi-stage process, including literature reviews and Delphi expert consensus and refinement. So why was this approach necessary? Why did he have to do it this way?
I think lots of reasons. When we first started to explore it and come together as a task force, we had some early conversations, debate. We explored what do you know about this? How often is it happening? We discussed that void of the combination of people who are doing it. And then started to have a look at the literature just fairly loosely on this topic, and could quickly see that there was not a lot of high quality evidence emerging. So we felt, it's easy. People have said to us, why didn't you jump straight into a systematic review and meta-analysis? Well, the answer to that was that there was this breadth of literature that we did not expect, because there's so many different conditions. So it came as a bit of a shock to us, the number of conditions they were using these techniques for, like autism and cerebral palsy. So as a result of that, we thought our best approach was to take a systematic approach to undertaking a scoping review. So we did this wide breadth, tried to capture the understanding, of all of the literature that existed there, and we synthesized that. We had a look at the quality of each. So we followed a levels of evidence approach to trying to draw out our findings wherever we could from previously published systematic reviews. But when the evidence wasn't clear there, we then went down another layer to RCTs where we could find them. There was not many of them that existed on this topic. So down we went to the observational and cohort studies and so forth. So once we got to the point of saying, okay, well, this is the current state of affairs. This is what's going on in the scientific literature. And we also looked at policies and guidelines and things like that existed and tried to map those out so we could see what guidance each of the professions might have been giving about the use of these techniques. So we had that, and then we thought, okay, we don't have absolute answers here, and we need to at least know what our profession thinks about this. And so then we moved on to the Delphi study.
Oh, what a process!
It's such a deep dive, isn't it?
It
Like
is,
you really,
yeah.
you know, there's nothing surface level about this. You've gone through every step so systematically and so thoroughly. It's really impressive. I imagine, you know, in doing that, you obviously ended up with a lot of information and a lot of evidence, or, you know, things that could be used as evidence. Can you talk us through some of the challenges in trying to synthesize the evidence base on spinal manipulation and mobilisation for paediatrics? I imagine there's a few, but what were some of the biggest ones?
Yeah. Anita, would you like to attack that, or would you like me to?
If you want to do that.
Okay. So I would say some of the initial challenges were just like, how do we actually display this breadth of information in a paper, like so that we can share what we know? And so we played with all different types of formatting. When we got to the stage of it was quite relatively easy to produce the findings of the Delphi. You know, as we went through the different stages of the Delphi, we were able to further and further refine and consolidate the findings. And obviously the scoping review wasn't too difficult. We just said what existed out there. But once we got down to those final stages of looking at the gap map analysis and going through those more detailed processes, that was where, excuse me, we had huge amounts of debate, and we were constantly trying to check each other's biases in that process. Yeah. So, we all came with our own bias, our own background, and we were constantly challenging each other on that process. One of us, we'd set out the methods that Anita had guided the task force on from her amazing experiences that she'd had doing Cochrane reviews and working with other people doing all sorts of great things around, looking at similar kind of research, but on different topics. And so we stuck to that process. So whenever one of us we would get somewhere and someone would say, but what about this? We're like, no, we're sticking to the method. And so we had to keep pulling each other in to stay on that method. And then the checking, because there was so much breadth of it, we had a lot of people constantly checking, double checking, triple checking that we had, when the levels of evidence from the systematic scoping review said there, for example, there's no evidence of effectiveness here, but our profession said, well, we are using it for this. We then had to decide, how much weighting do we put on that? How much weighting do we put on this part? And also with our knowledge of the adverse events that are occurring, the harms that are noted in some of these papers or reports of that in the media, we were weighing that up constantly as well to make our final decisions.
Wow. So on that...
And equally with that, we also looked at the outcome measures within each of the main papers that were there, and ended up conducting 2 systematic reviews on the psychometric properties of key clinical outcomes that emerged from the scoping review. They related to patient-reported, observer-reported, clinician-reported, and performance-based outcome measures. And basically from that, we only found 2 outcome measures, the PEDS-Q quality of life inventory for neck and back pain, and the Alberta infant motor scale for torticollis, that had reliable, valid, and responsive to change information, because we wanted data that could pick up change over time as well. And additional to that, there were 2 outcomes, the autism treatment checklist and for autism, and the latch, which is the latch audible swallowing type of nipple comfort hold for breastfeeding difficulties, but they only had reliable and valid outcomes, but certainly no evidence available on responsiveness to change. So therefore, there was a lot of missing evidence. There was a lot of information there, but the valid,
Measurable.
reliable, responsive evidence very limited. And the we did a large scoping review, systematic clinometric review on these properties, and which took quite a bit of time. And we were both, I think, probably fairly shocked with the lack of evidence on these two, on any of those 4 categories of outcome assessments.
Oh.
It shocked us. Some people challenged us after we had published the systematic scoping review, saying, how come you didn't include my study in there? And when we looked at some of those studies, we're like, we didn't. What is this that you're even doing? We can't tell what you've done in the first place to the infants in your study.
Yes.
And secondly, you haven't used an outcome measure that has been validated with the populations you're using. And if it's not a valid measure, how do you know it's
That's right.
measuring the right outcomes?
Yeah.
So, it really instantly made us think about what is it you're setting out to try and have an effect on, how are you actually measuring that? And so that was our responses back to some of these people.
Yeah.
I mean, it's so interesting, isn't it? The themes remain the same when if you publish a paper, it doesn't mean that it is of good quality. You can publish a paper, but you need to be transparent about your intervention, describe it, but you also need to describe your outcome measure. And when you do look at these areas, and it's published, but the outcome measure isn't valid. It's not one that has been tested for time, but yet it's been held up as we can see an effect. It just shows that whatever you see sometimes, if it's a social media summary or something you see online, you do have to go a bit deeper to find out what it is, because the common threads exist through all sectors of health, I think.
Yeah.
The same themes, aren't they?
Yeah. And I don't know,
Very true.
Perhaps this is just an anecdotal observation, but something that I've been talking about with other colleagues recently. I feel like more contemporary evidence is better at reporting, more rigorously and adhering to checklists. And I think journals are doing enforcing that more, that you have to, reporting guidelines are much more prominent now than perhaps they were 10, 20 years ago. And so depending on when the evidence was published, you can have a really hard time, and this colleague I was talking to is also doing a systematic review. So, it's really tricky to try and fill in some of those gaps and infer things from a publication when perhaps those reporting guidelines weren't adhered to, or, there just wasn't that knowledge around them.
I definitely think we're getting better, and our expectations as a physiotherapy profession should be that we are following those guidelines for reporting.
That's right. So
I think one of the sorry, I know you want to ask questions.
Yeah,
but I think one of the major gaps or the highest research gap, not only in the pediatric literature but in other spinal literature as well, is the lack of inclusion of standard documentation and reporting of adverse events in clinical trials on manipulation and mobilization, and that was a key variable here as well, that limited reporting of adverse events and actually being able to systematically report it in a way that all of us would understand was a key gap. And the other barrier there always is in randomized controlled trials, severe adverse events aren't going to be coming up as very well if it's 1 in 300,000 that an adverse event occurs. So systematic reviews and lower level studies, and that's where we found our adverse event information is more in case reports or cohort trials.
Sure.
And other systematic reviews as well.
Yeah.
So we found that 50% of the conditions that were identified by our review, both musculoskeletal and non-musculoskeletal conditions, noted some form of adverse event in this pediatric population. And then the severe adverse events were reported mostly for spinal manipulation, specifically in the area of neck pain for children, or torticollis for infants, or headaches in the younger child. And then more moderate adverse events reported for, again, manipulation in colic and nocturnal enuresis. So that enuresis is like peeing the bed, I guess, in children and adolescents. There was, however, no evidence of severe or moderate adverse events reported in spinal mobilization. But there was mild adverse events identified, especially in this disorder called KISS. I meant to look up what that meant. Kinetics, something.
Kinetic imbalance, yeah. That's the one that they talk about when the baby's born, that their spine is malaligned. And
like if it's been a difficult birth or something,
Correct, yeah. So that's where we're seeing a lot of midwives refer off.
Right.
What they identified there was that 53% in one of the cohort studies had vegetative reactions. So those were things like flushing, reflex apnea that lasted 10 seconds. We found that quite extensive. Hyperextension posturing, sweating, bradycardia, tachycardia. And we felt they didn't feel that was of concern. That was not an issue to them. But we as a team of clinicians and a team of scientific scientists, I guess, were very concerned. And we thought these were maybe even near misses of something like a SIDS, or a sudden infant death syndrome. And we just don't know. And so like this area of adverse events and actually defining it and making a determination of intensity frequency will be a key outcome measure that's needed for the future and needs to be tracked by both clinicians and anyone who does any clinical trial.
Yeah. What happens with those adverse, I mean, that was literally my next question for you, Anita. So you're in my head, so it's fantastic. Because it's the adverse events that we know about, like I remember even in uni, you don't do cervical neck manipulations. You've got a test to make sure you've got, that it's safe to do so. There was reports of strokes and things like that made me cautious anyway, right from the outset. So as a clinician, you need to be reporting adverse events to your board. Like, do we know if that happens? Because how do we know otherwise in practice what's happening? Obviously, what you've seen is case reports and cohort studies that have been reporting it, but is the incidence possibly higher, based on reporting?
I think one would think that you would report those adverse events. The reality is, I think, in practice, that they are having something done, spinal manipulation done. If you can think about how tiny babies' necks are and how precise could you be, how much force do you know you're putting through their spine? I don't know how anybody could actually get that right.
No.
And so those babies, they have that manipulation done, and then they leave the practice. And that whilst they might have some of those responses that Anita just referred to occur in the rooms, which to us were like near misses. Like I would, in any treatment I did, if I saw those responses, I would pull right back. I would never progress with the treatment if I saw vegetative states after it or things like that. So they leave, they go home, and then something happens. And then the parents present, we believe, to emergency departments or their GP or other people. So we're hearing repeatedly anecdotal feedback from our emergency department physios. So we now have a number of them working in emergency departments that are telling us, I had this child who had paralysis after spinal manipulation, and I've had this child that had a stroke after spinal manipulation. And so they're seeing them occur there, and they're not, even though their history has been manipulation occurred, then this has occurred, they're not being linked together and reported off in our country to our registration authority, or in other countries it should be to the licensing authorities. So I think that's where the body of work needs to occur, and that's on our radar as our next big study is to try and get some emergency department auditing going on to see how often is this happening. That's still not going to be all of it, right? It's because a lot of them won't present. So we know there's a lot happening in between, and trying to capture that's very hard. But at least we want to know how many of these adverse events that report to the hospital are as a result of spinal manipulation prior. So,
and the ones that are reporting to the hospitals are likely a little bit more severe. And the light transient ones, I think Cote, and there was another osteopathic review that was done as well, pinned it at 0.3%, the incidence of a mild transient symptoms at between 0.3%, and it has confidence interval, to 22.22%. With the confidence interval. But that falls to about 1 in 4 having some episode of mild, that transient short loss of breath, that extension posturing for a short period of time, which is still considered mild by clinicians who are doing this. And the more harmful sustained events that were reported in the literature, for example, in a child with cervical neck and back pain, the severe adverse events were more like unsteady gait, poor coordination, drowsiness, hospitalization. And that was a 12-year-old girl, or a history of with another girl with who had a history of congenital torticollis. Another example was progressive defect in legs, clonus emerging, urinary incontinence, paraplegia, also in a 12-year-old young girl. And infantile torticollis, example of severe adverse event was subarachnoid hemorrhage and death, or quadriplegia. And these were in a 3-month-old and a 4-month-old.
Oh, my gosh.
And so one severe for cervicogenic headache was bifrontal headaches, vomiting, facial weakness, diplopia, ataxia, in a 7-year-old gymnast child who was getting manipulations. So
and they're just the ones we know about.
Reports.
I feel speechless at the moment. That's very frightening.
Yeah.
I don't know about you guys, but when I see that, if I know that, and a lot of clinicians don't know that, right? So when you read this information that's in our position statement and the reviews, it would be enough for me to go, I'm going to look for an alternative type of therapy that I could do with this population where it has lower potential risk of harm.
Yes. And so
better effectiveness.
Yes, for sure. And I mean, I think based on that conversation we've just had, it kind of is implied that your statement makes really strong recommendations against spinal manipulation for infants and children with non-musculoskeletal conditions. But I'm just curious, how, given the lack of high certainty evidence, and given, this conversation that we've just had around adverse events, how do you, in your opinion, how should clinicians be kind of managing conversations with families who might be asking about spinal manipulation for their child?
Yeah, I'm happy to answer that, Anita.
Mm-hmm.
I think when I think about the way you engage in paediatric therapy, we're very family-centred in the way that we work with infants, children, adolescents. So often the family member is there with the paediatric child or infant that we're working with. So in my opinion, we have an obligation as a registered physiotherapist, no matter where we're working in the world, to go through that process of shared decision-making with them, where we explain what we know as the current state of affairs, the evidence that as it stands at this point of time is this is the level of evidence that we have in terms of effectiveness. In this case, we have no high-level research at all when we look at the synthesized research to say that there is any effectiveness from these techniques with any of these populations, whether it doesn't matter what we're talking about. If we're talking about manipulation or mobilisation, we don't have strong evidence to say it's effective. So then after they know that, they should also know what we know about the harms. So we should be sharing there is a risk of harm, and this is what we know has happened in the past. And if you share that with parents and you're ethical in your approach and making sure you're doing shared decision-making, then parents are going to be informed to the fullest extent that you could offer them. And then, if you still proceed after that and the parents still want to do that, then at least you've shared the current state and the parents are informed before they make those decisions to proceed. I can't imagine a parent who would proceed once they know what we've just talked about.
Yeah.
So
for sure, we do not know the risk rate. So these are maybe one-off. And if you had hundreds of thousands of people, it may be 1 in a million for all we know. We don't know. But on the since we have alternative approaches, basically, why not choose another approach first?
Yeah, absolutely.
Would be my approach.
Yeah.
Certainly for there is some good news in this in terms of spinal manipulation mobilization. So for treating that adolescent with a musculoskeletal condition, with some kind of spinal mobility impairment, or either in the neck or the back, or neck-related headache, that group we think may benefit from spinal manipulation. And I think it's the Delphi that really drove that decision towards suggesting that it may be appropriate, but we can't say it is appropriate, but we think that's a zone where there's some opportunity for a good research to be done. And the risk rates seem to be, we don't know what the risk rates are, but we didn't get a lot of adolescent case reports. We got infant case reports, we got young child case reports, but we didn't get that a little bit older child that's coming very close to being an adult. A lot of case reports on that group.
That's really interesting. And I guess one final question for me was what role does our professional bodies have to play in this now? Because we all are held to our professional bodies. We have to be registered. There's obviously a responsibility for us when we're interacting with families. But for our registration bodies, is there a recommendation there or advocacy that we can have in this space as well?
Yeah, I definitely think so. In Australia, for example, when last year, about halfway through the year, the Australian Chiropractic Association made a decision to self-regulate and allow their chiropractors to start manipulating infant spines again. And as a result of that, the media blew up again, and the politicians got involved, and they then went to the professions like physiotherapy, the medical profession, etc., and asked them for their position on it. And so we were really lucky. We literally had published the position statement 4 days before this blew up.
Talk about timing.
And and so they were able to just pick, the physio profession were able to just pick this up and use this in Australia to push back to the politicians, say, you know, we're supportive. So the APA were able to use that and say, this is the position of the physio profession. And we're able to advocate for the ceasing of that practice to occur. So the political impacts then in Australia were that they could reinforce that ban and ensure that the chiropractic association and chiropractic profession would not continue again to do that. So that's back under the interim ban again at the moment. So I think there's a body of work around advocacy for the Australian Physiotherapy Association and every other countries, all the World Physiotherapy member countries, to be able to use this information and advocate for change if it's needed in their countries.
Yes.
And in terms of regulatory bodies, our accreditation and licensing bodies, you know, I think probably there's more work to be done there on the mandatory reporting of adverse events if people are using this. So I would, you know, when we do our ARPA registration each year here in Australia, we have to say whether we've had any, you know, episodes of that would need to be reported. They could add a question there about, are you using these techniques, and some, you know, identify some obligations.
Yes.
And so that's some work that I think as a profession we need to probably do across the world.
Yes.
I know, Anita, you've had different things going on in Canada as well in terms of it's now informing curriculum, and that's where we need to go as well. But do you want to build on that, Anita?
Yeah, and different countries are different on this. There's countries that have, like the Netherlands and Germany, they have a subspecialty within physiotherapy that does manual or manipulative therapy on infants. And so it threatens a livelihood as well. So some of the countries will have a lot of challenges, and the clinicians and the researchers and the system really has to pull together in order to make determinations on what the risk rate is, perhaps in their country or their specific cities or their ER departments close to where those physios are working, and that reporting of adverse events actually starts happening. In other countries, our country doesn't seem to. In Canada, we don't. The physiotherapists don't manipulate infants very much, so the uptake is already right into the level of the curriculum, and certainly the advanced trained physiotherapists in OMPT. We only have 2 or 3 schools in that field, and it's already being examined in that. But we're a small group. We're a small, big country, but a small number of people. So it's in a small relative volume of physiotherapists that do manipulation. So it was easier to integrate into the system. However, that being said, we still have the questions coming to us. Oh, the daycare. One of my students, Dave, was saying, wow, I just got a gentleman. He came in so angry. The daycare sent out newsletters to have not only the young child manipulated, but perhaps the parent as well, so that they'd be more calm with their child and everything would be calmer in the house.
And that's happening here in Australia. They're sending letters home to say, we can manipulate your child with autism, and we can also manipulate your spine as a parent that will help with your bonding. So we are literally seeing that locally here around us. And I'm glad to say that's not the physio profession that we're seeing do that. It's others, but that's what we're up against in terms of protecting the the safety and well-being and great outcomes of the same children that we see in physiotherapy.
Yeah. This is such an important conversation, and I think, your position statement is a really effective tool to start to guide some of the conversations that people are having in this space. Yeah.
Something to refer to. Goodness me.
Yeah.
And Anita, did you have something? I can tell you've got something else.
Just one more question, one more response to
Go for it.
this broad discussion. We're in terms of the literature, we're certainly in agreement with some aspects of chiropractic. There's certainly two camps of chiropractors and osteopaths as well. So you want to do minimum harm with manipulation. There only seems to be minor adverse events in the literature. We agree with that. It has little to no effect on non-musculoskeletal conditions, although there's some osteopaths, some chiropractors that are opposed to that concept. That should not be recommended for asthma, otitis media, cerebral palsy, things like that. But we're in disagreement with one of their main chiropractic guidelines that basically suggests the absence of research evidence does not equate to evidence of absence, and therefore you should not deny people care as a consequence to that. That's how they read it. We read it differently. So that absence of evidence does not imply an absence of harm. We emphasize that the spinal manipulation mobilizations pose some risk, but we don't know what the risk rate is, particularly in infants, especially in young children, and should not be used in that population. But perhaps the evidence will change, but at this point, we're really not recommending large clinical trials in this area until we've got some basic science information in some of these areas to say this is even of value for that condition, like ADHD, for example.
Especially when there are other evidence-based guidelines that can be used that do have effectiveness.
Yes, absolutely.
And a more robust evidence base behind them.
Yep.
Absolutely.
Yeah.
That is fantastic. Well, we have talked for quite some time about this because it's just such an interesting topic, but we're not quite done yet. I think it's time for Ed, hey? So let's go to our final segment, Tell It to Ed. Ed, as you know, is our producer. He doesn't have a background in child health or anything to do with the spine, mobilizations or manipulations. So he's been listening on this conversation and I can see that he's been taking some notes as well. But before he has an opportunity to ask a question, I'll get one of you, Nikki or Anita, to give a 60-second summary of this position statement or what we just spoke about, and Ed will have time for one question. So who's going to take this one?
I can take it.
Go for it. Thanks, Anita.
So from a cautionary and safe care note, spinal manipulation and mobilization should not be done on infants and not be performed on non-musculoskeletal pediatric conditions. And we discussed all types of those. Neck and low back manipulation may not be performed in children. And from an evidence of benefit perspective, spinal manipulation and mobilization may be appropriate to treat musculoskeletal conditions in the adolescent.
Beautiful summary. Thank you so much, Anita. Thank you. Ed, are you ready for a question?
I'm nervous about Ed's question.
I hope so.
He looks nervous too.
You can take Ed's question, Nikki.
Everyone's nervous except us.
Yeah, that's right. We just sit back and listen.
I've been nervous over 200 times now. So, look, sitting on these conversations is always enlightening, and I love the quote: the absence of evidence is not the absence of harm. And I think, well, from what I've learnt so far is anecdotal evidence seems to be enough for some clinicians to use, like non-evidence-based interventions. And yet even the anecdotal adverse reports are either ignored or not even logged. And I guess I don't really understand how evidence-based practice is not the first port of call for interventions. And is the question that current knowledge is just not made more available, or is it, deemed outdated? I guess I'm asking the question of why, and academics and researchers seem to be the most informed, but in practical application, clinicians don't seem to understand or trust the current evidence maybe. Is too much trust placed in their day-to-day clinical observations? So, or is it driven by patients and families that see a lot of snake oil on the internet? Mm-hmm. And I think my last comment to all of this is I seem to see the Dunning-Kruger effect at play here. And so it seems like the more you know, which, researchers and the like, the more you seem to understand that maybe you don't know or you don't understand it as you did before. Mm. And yet this kind of intense confidence in outcomes seems to stem from non-evidence-based interventions, and researchers are super, super careful about what they say and recommend. And I'm not sure that the uninformed seem to understand enough. So long-winded question
long-winded,
is,
but yes, good.
How do they become more informed?
Oh. Did you guys follow that?
Yeah, I think so. How do they become more informed? I think they've got to have that strong desire to seek the evidence. But, it's taken us 5 years or 4.5 years to get to synthesizing. We're all experienced researchers to pull this all together. Mm-hmm. So when you're a busy clinician doing that, it's kind of not possible. So we need to do better as clinicians, and you're doing a great job here. Is an opportunity for us to share this evidence out with the wider paediatric community or others who are interested in this topic. So sharing, researchers need to be able to just not only pull the works together and publish it, but then disseminate and share it and make sure it's reaching the end users. So make sure it's reaching. And when I say end users in this space, we need it to reach not just the physios, because the position statement's for them, but also that the findings from this reach the parents, the daycare workers, the midwives, the doctors who may be helping parents make decisions about where to go for their treatment here.
Yeah. It's a great point. And it's not just enough to put the information out in one way, through a publication and just assume that by osmosis it's going to get where it needs to go, because we know that the right information needs to be delivered in the right way to the right people. And so, for all those different people that you're talking about there, they're very different strategies, right? To reach the medical profession, to reach the families, to reach the daycares. Yeah. It's quite involved.
Who may be going off anecdotal evidence because they haven't read or have seen any of this evidence, right? And so what they've seen is almost like a confirmation bias. Yeah. Anita, do you have anything else to add to that?
Certainly one of our future directions is to look at the decisional needs of parents in this field, and we didn't have the parents to come in and help us evolve and build this evidence, but we're certainly chasing down the decisional needs of them and hopefully be able to put this information in a place, a decision aids place like the Ottawa decision aid. Now that the name of that actually jumped out of my brain right now. But there's a decision aid place where you can look up different types of treatments and see what the evidence-based decision is for that specific disorder type. And so while we determined there's maybe in adults not a decisional need for manipulation, mobilization, I think there's such a gap here that parents don't even know there is controversy and there's a decisional need present for them to really look at both sides, the harms and the benefits for all the various pediatric conditions. Anyway, that's an expansion on your expanded answer to that simple question.
Thank you.
That was wonderful. Gosh.
And thank you for the great question as always,
It
Ed.
was, very insightful. It was long.
Thanks,
but
Ed.
it was good to follow it.
Your question.
Sorry about that.
You see you smiling. I think he's happy with the answer. Well, thank you so very, very much for speaking with us today, walking us through this position statement.
Yeah.
It was very eye-opening. I do
Certainly
feel
was.
slightly ill about some of those adverse events.
As do I.
And this is why it's so important to spread this knowledge. So thank you for staying up late, Anita.
Yes,
I'm looking at the time.
thank you,
Definitely past my bedtime if that was me.
Yeah.
And to all of our listeners, remember you can head to our website, researchworks.net. We'll put a link to this paper there as well. So please do go check it out.
Yes.
It's a wonderful paper to read.
And a huge amount of work that's gone into it.
Like I said,
Time
4.5
and
years.
effort. And thank you, Nikki. Thank
Very
you, Anita.
passionate. Yes.
Thank you.
Thank you. And to all of our listeners, we'll talk to you all again next time. Bye.
Bye.
Bye.